Welcome, everyone. It's so good to have so many of you here. My name is Anne Marie Trioni, and I'm with MIEC Insurance. And this is the first panel for our Pointing to Safety Expert Panel webinar series. Today, we're going to be talking about understanding how malpractice claims happen. This series came about a year ago where Ben and I were at a conference and we got to talking about what are some things we could collaborate on, and we wanted to talk more about claims and risk management, and then it evolved into us connecting with Anthony and Lisa, and then also reaching out to quite a few other sponsors, which Ben will talk about shortly. And about a year later, here we are. So we're really happy to be sharing this information with you. Let's see here. So let's do a few housekeeping items. Mike touched base on some of them, but let me go over some of them again. The handouts, Mike is going to put a link in the chat to the website where you can download the handouts, and there's 4 of them. So one is the primary handout. There's one set of slides from Lisa, and there's also a handout from Anthony. And then there is a summary of our sponsors and special offers that they are providing to attendees. We are recording this. We're going to send out that recording next week to all registrants. As Mike said, at the end, we're going to be doing an interactive Q&A with attendees. So if you have questions that you want to ask them either now or at any point during the presentation, please put them in there, and Mike and I will collect those and go through them. With over 100 attendees, we're not going to be able to get to everyone's questions, but we will do our best to find major themes. They can really only respond to general topics. So if you have a specific situation with a patient, they can't get into specifics. As you know, we are offering continuing education credits. So at the end or towards the end of the session, we're going to put a link up where you can go. There's going to be a form on the website that you're going to fill out. And then we will report the NCCAOM credits, your name to them to get your credits. And then we will send out certificates for those who are also seeking California credits. All right, Mike, can you go to the next one? The next slide. Okay, so here's how we're going to have things set up. Obviously, we're doing welcome and introductions, and I'm going to hand it over to Ben Zappin, the co-host and moderator, here shortly. Then our panelists are going to do we have 3 panelists. They're going to be doing mini presentations on their area of expertise. And then we're going to move into an interactive discussion. So Ben is going to, throw out some moderator questions and get the panelists talking about a wide variety of things to go a little bit deeper. Then we're going to transition into a question and answer with you as the attendees. And then at the end, we'll wrap it up. And okay, go on to the next one, Mike. All right, so host and moderators, my name is Anne Marie Trioni, and I'm the direct account manager for acupuncturists at MIEC Insurance, and we are a medical malpractice insurance company located in Oakland, California. And Ben is a co-founder of Five Flavors Herbs in Oakland. I think it's been around for over 10 years, is that right?
Five Flavors Herbs is no longer in Oakland. We now exist solely in Grass Valley in Nevada City, in the Sierra Nevada foothills.
Okay.
And there is still an herbal pharmacy that we left behind serving the community.
Okay.
So, my name is Benjamin Zappin. I've been a licensed acupuncturist for over a couple decades now, and working with herbs for about 30 years. Co-founded Five Flavors Herbs with my wife, Dr. Ingrid Bauer, and we've operated herbal pharmacy, finished product. We make liquid extracts and have been serving the herbal and Chinese medical community with our liquid extracts and blends that we make. We're also a contract manufacturer. So we've been we've been an FDA regulated company and are attuned to the industry and are navigating safety and risk on a regular basis and in dialogue with acupuncturists and herbalists, giving them resources to mitigate risk. So that's why this is an ongoing topic of interest of mine. And I guess with that, the herbal industry self-regulated with the Deshay Act in the early 90s, and we'll talk a lot more about this with Wilson Lau in a couple sessions. And it's that with, we maintain our freedom, we maintain expanded scope of practice with self-regulation and vigilance and caution. So that's the inspiration with which I, wanted to call in some of these other industry leaders, that is Chinese medical practice, acupuncture practice industry thought leaders. So starting with, I'll introduce my old close friend, Anthony Vandermoel, who I had the honor and privilege of taking classes with and studying for our LAC boards with in 2003. We both passed. And I've seen Anthony go on to found AOM Professional, and which is an educational resource. I've also seen Anthony become one of the most sought after speakers and educators in orthopedics and case management, risk management in DAOM programs. And get to hear a lot of buzz from DAOM students, chiming in about this great educator. So I get to see the good work my colleague and dear friend is doing, and really honor that, and really glad you're here. And we'll let you share more about yourself. And Lisa Releder, I hope I pronounced your name right.
Rollletter, close enough.
Rollletter, thank you. Is somebody else who really has, now, I know you won't take all the credit, but you've led an initiative that has really changed how acupuncture is practiced in the United States. And I really celebrate that. A founder of Working Class Acupuncture and Pocatech University has enabled access for, I would guess, millions of people across the country that may have cost as a barrier to acupuncture, and has provided a framework, a really thoughtful framework that you're going to be sharing, and you're going to be sharing a bit about trauma-informed care today in the context of safety. Really glad you're here. And Ashley Hahn has been with MIEC for, I'm looking forward to hear how long. But I've been, for how long?
20 years.
Okay, incredible. I used to live around the corner from MIEC in Oakland, so I would walk by there when I took my kids to preschool. Really looking forward to your perspectives, and I've been an MIEC consumer for a decade and a half, and really appreciate the quality of service we get. For anybody who's tuned into this, you're going to get so much bang for your buck today that we guarantee your money back if you don't get more value than you would out of a weekend manifest abundance with your thoughts and intentions retreat over the next 10 years. So start tracking that now. And sorry. What's our next slide? So our sponsors, we already mentioned a bit about MIEC, Five Flavors Herbs, AOM Professional, and Pocatech. We also have the CSOMA, is
California Society of Oriental Medicine and Acupuncture.
Okay, I thought they tried to change their acronym. So it's,
Oh, did they?
yeah, who is a Bay Area centric practitioner focused organization that a lot of us have participated in. We appreciate their support. Maury West Seminars, New Herbs. Can you tell us more about Maury West Seminars?
So Maury West is she runs a billing company that teaches classes on proper billing and documentation, and also has a company which will do the billing for acupuncturists. So she was very keen on supporting this because she's a real believer in proper documentation as a part of being in practice, which dovetails with documentation outside of just getting reimbursed for insurance, but also for documenting the patient encounter correctly.
Okay, thank you. New Herbs is a standard bearing bulk herb, multi-product TCM brand that was founded out of a herbal pharmacy, and the president, Wilson Lau, they operate their company also out of Oakland. Literally grew up in his dad's herbal pharmacy that's in downtown Oakland, Draylene Tong, that you can still visit if you're ever there. They're a standard bearing industry organization that imports TCM herbs, are major stakeholders in American Herbal Products Association, advocates for transparency and quality, and one of the largest importers of organic herbs in TCM. ACMA, could you tell us a little bit more about ACMA?
So that is the American Association of Chinese Medicine and Acupuncturists. So similar to CSOMA, it's an organization that has a large membership. Most of the members are Chinese speaking. So they also do a lot of advocacy and teaching and serving that portion of the profession. And I believe they have an annual seminar that they put on with continuing education classes.
And AccuCare is an acupuncture network that credentials and lists acupuncturists in preferred provider directories in the insurance industry, such as United Healthcare. They operate in California and New Mexico. They were founded in 1994 to connect acupuncturists to patients and payors. The network of licensed and credentialed practitioners share the goal of introducing TCM into today's managed care environment. They negotiate with insurance carriers to get reimbursement rates accepted by our members, and do not take a fee from the practitioner's reimbursements. So, the uniting cofactor here is that all of these sponsors are really committed to serving the professionals, profession, and consumers for preservation of broad scope of practice and safety. So, we'll hear more about those at the end if there's time. If not, there's a summary going out that includes how to access all these sponsors. We really want to offer an extra layer of acknowledgement because all of them pulled some weight to share this with their network. And that was all we asked of sponsors. We're not taking money from sponsors. Everybody's making a contribution of their time and energy and sharing their network. You want to talk about learning objectives, Anne Marie?
Sure. So these are the primary themes that we're going to talk about. We are going to talk about some other themes as well, but I just wanted to orient everyone towards, we're going to cover the most common types of adverse events and claims that occur in clinical practice. What are the contributing factors that increase the risk of claims? Because many of those, the practitioners have some control over. What is the role of documentation in supporting you in your defense if you are to have a claim? And then a lot of the times practitioners are asking like, well, what do I do if a patient is upset? How do I respond to an issue with a patient, or if there is a claim that's filed? So we're going to discuss that as well. And then what can you do proactively, not just responding to a complaint, but what are things you can do proactively with the patient in order to de-escalate an adverse event into a claim? And I think that is it for the slides for now. Ben, go ahead and take it away and transfer it to the panelists.
And I think our first panelist is going to be I believe that's going to be Ashley, correct?
Yeah, I think so.
Yeah.
Yes.
Okay. Um, okay, so
Tell us a little bit more about your role at,
at MIC.
yeah.
Okay, yeah, so I'm Ashley Hahn, I'm the claims and PSRM accounts and operations lead. I've been working in claims in medical malpractice for 20 years. That's all types of care. Acupuncture, I've handled acupuncture, medical board matters, acupuncture board matters, litigated cases, a variety of claims, pre-litigation, and just garden variety calls from acupuncturists. But beyond that, in 20 years, I've also handled, multi-defendant litigation with, orthopedics, neurosurgery, birth injury cases, a whole scope. So when I talk about medical malpractice claims, I'm very passionate about the topic. I think that's a common denominator for folks at MIC. And so I want to speak tonight, though, basically about what I've seen in my experience with regard to acupuncture. There are some things that do happen with all claims, sort of, some universal truths of healthcare and claims. But I'm going to focus the discussion really on acupuncture. So I will say just a general thing I've observed, claims occur. If you drive on the roads in 40 years, something's going to happen while you're driving. I think it's a little bit similar when you're practicing in healthcare. Claims occur. And I think that the important things to think about are what are the things you can do in your daily practice? What are the things you can do when claims come up to mitigate them or to address them in a way that's going to be beneficial for you and beneficial for the patient? I know everyone, you go into acupuncture because you want to help. You want to help someone get to a better place. And you can do the same thing when a claim comes up. Most common types of claims in the acupuncture practice are burns, pneumothorax, and reaction to treatment. And when I say reaction to treatment, it can be anything from someone has more pain than, more pain aftercare than they had before. Sometimes, depending on the treatment modality, sometimes patients just have a reaction. It's the same thing with some patients have a reaction to treatment modalities in any medical specialty. I will say the thing about pneumothorax that is more significant in terms of where it fits in with what I've observed with acupuncture claims is pneumothorax is a precipitating event that always requires immediate follow-up care, presentation to a hospital evaluation, ER. Sometimes Thor events are placed. You have medical intervention that requires a series of things to occur. So the reason pneumothorax is significant, obviously, it's an acute event, needs to be addressed immediately. But in burns, pneumothorax, they are significant with regard to claims or litigation because follow-up care is required, and there's usually medical intervention, and there can be costs that a patient doesn't expect. So that brings me to my next thing, which is what are the factors that drive claims and lawsuits? Unanticipated costs for medical care that a patient hadn't anticipated, follow-up care. They have to have various topical things to address a burn or something to address maybe a skin reaction. Medical expenses, lost wages, not going to be able to go to work for a little while because they're nursing a healing element of their body. They can't put weight on a foot, something like that. Other costs that are associated, someone, can't walk their dog and they have to hire a dog walker. These are things that occur to people when they get injured. There are costs they don't anticipate. And so when we talk about damages with regard to any injury, a claim or a lawsuit, that is what that speaks to, something that a person didn't expect. So, the other thing I wanted to talk about is reporting. So, what are the things to report to a medical liability carrier? What and when should you report? Adverse outcomes in the absence of a written claim should be reported. So a patient has an immediate reaction to treatment. A patient calls you 3 hours after care, I'm having trouble breathing, you refer to the ER. It would be a good idea to put your carrier on notice. I will say a caveat here, be very familiar with your contract with your own carrier. Your carrier might have particular provisions about reporting matters. It's very important to familiarize yourself with that, with your contract. Carriers are different. Carriers offer a variety of elements. I mean, I'm very familiar with what MIEC can offer, but your carrier might have particular provisions about reporting. But an unexpected outcome in the absence of a claim, patient falls off an exam table. We've seen that, things like that. Another time to report a matter to your carrier is anything in writing. And when I say in writing, in the world today, when we think about claims and when we think about in writing, so to speak, text, email, correspondence, text and email is considered something in writing if someone, and part of that is around the perception of the sender. When I have observed when patients send texts, they consider that, I've contacted you, I've put something in writing. So it's important to acknowledge those. It's communication from a patient. I'll talk a little bit about that more in a minute. Any legal document of any kind, a subpoena for medical records, a subpoena for your deposition. Sometimes that happens because acupuncturists are treating someone secondary to a motor vehicle accident. I've seen this happen a lot with all providers. It happens most prominently though with physical therapists, acupuncturists, orthopedists. So a subpoena of any kind, a summons and complaint of any kind, that might be from civil superior court, that might be from small claims. Any letter from a patient, any letter from a patient's representative. Those are some things that I would report, or I would suggest reporting. And in terms of responding to a patient, if a patient, sometimes there's nothing in writing, sometimes the patient shows up for a follow-up visit, sometimes the patient is upset, they're complaining, they're agitated about something, they had an expectation of how they would feel and they don't feel exactly that way. The most important thing to do, the most critical communication tool any healthcare provider has, is the ability to listen with an open mind and to allow the patient to say what they need to say. It is my observation that many patients want to be heard. And sometimes it is best to not respond in the moment. Sometimes it's best to just let the patient explain what their concerns are. I understand. I'm going to give that some consideration. Sometimes it's best to just say that. There's a whole scope of ways to engage with a patient when something happens. I know that's going to be covered in other modules in a little while. So I'm not going to talk very much about that here. And then some ways to protect yourself: establish a custom and practice. And when I say a custom and practice, this is what I've observed is if a provider has a custom and practice of how they evaluate, how they document, how they take a history, how they develop a treatment plan, How they establish a plan for follow-up care. The reason that's important is when you have a custom and practice, in the event you're deposed or in the event you have to talk about the way you treated the patient or talk about the way you addressed a presentation, you don't necessarily have to remember every single minute of interaction with that patient. But if you can call upon your custom and practice, you can say, when someone presents to me with radiculopathy, this is how I examine them. These are the things that I go through. These are the things that I begin to rule in and rule out. These are the typical ways in which I address it. These are the periods in which I determine that x-rays are important, or determine that there needs to be medical intervention by an orthopedist. So when you have a custom and practice, it's almost like an outline for how you can move through the treatment process. Document medical history, take a very thorough medical history. I have seen a lot of cases, litigated and otherwise, where failure to take an accurate medical history can impact the claim. I'm going to try to move through this a lot more quickly here. I don't want to take up too much more time. Establish your treatment plan. Have the informed consent discussion and document that you've had it. The most important thing about informed consent is the discussion. It's the communication with the patient. The documentation of that is critically important as well, but be certain to make sure you have given the patient the opportunity to ask questions and you've answered them. The last thing I'm just going to say here is establish practice policies with regard to appointments, billing, cancellation, things like that. I've seen a lot of antagonistic communication where a patient cancels late and it's sort of, it conflates into something bigger and it doesn't. So if you have practice policies that are made clear at the outset, that could really help just establishing a foundation for good communication in the treatment scope. So I'm going to stop here because I don't want to take up too much time, and then I can certainly address questions.
I think we'll move on to Q&A a little bit later.
Yep.
Okay. Thank you, Ashley. Really appreciate your insights, and we'll have more time to ask you questions later. Our next panelist will be Anthony Vandermoor. Anthony, will you share a little bit? I introduced you, share a little bit about AOM and share about what has inspired you and motivated you to make this an area of focus for yourself.
Sure. Yeah. Thank you, Ben. Yeah. So I'm an acupuncturist, like most of you here in tonight's webinar, and I was licensed in 2003 after obtaining a master's degree, and I specialized and focused almost right away on orthopedics and sports medicine and pain management, which was my area of interest. And it was around in 2009 when I just happened to see on the website of the California Acupuncture Board that they were in need of what they call subject matter experts to advise the board as to whether a complaint that had been filed by typically by a patient or sometimes another party was weigh in on whether the acupuncturist who was the subject of the complaint had been following sort of professional standards of care or not. And I thought, that's interesting. That I'll probably learn a lot from doing that. So I just kind of threw my name in the ring and started to receive some cases from the acupuncture board. And right away, I was like, wow, these are really interesting. I'm learning all kinds of stuff that I was not taught at the master's level, had no idea could happen, would happen. And I want to do more of this. So I sort of put my name out there for attorneys as well in civil malpractice suits. And it began to dawn on me as well that if licensed acupuncturists like myself didn't play this role, that attorneys would go to medical doctors, chiropractors, physical therapists, other medical professions, and ask them, well, what's the standard of care? And I think I'd rather be that I'm, an acupuncturist like me is doing that rather than somebody who isn't trained in or doesn't, really do acupuncture as a full-time profession, because when us as expert witnesses say something, testify in a malpractice suit, or write a report, or are deposed or whatever, that builds, that adds to the standard of care. So I would rather that the standard of care for our profession be defined by us as our profession, rather than by outside entities. So I began getting contacted by attorneys. I would say typically since 2009. It fluctuates. It's a little irregular, but about once every couple of months or so, I'll get a call or request. Would get a request from the acupuncture board to weigh in on a claim or a complaint, so they do happen. I'm just one person, and it's like, oh, I'm getting a call every couple of months. There's definitely activity out there. In fact, I got a call just this afternoon that I haven't even had time to respond to, so I don't even know what the case is about yet. But so my role as an expert witness is kind of like a baseball umpire. It's like, call it like I see it, follow the rules, regardless of how the crowd is roaring on either side of me, and ignore the noise, just or like a judge in a court of law in some sense, and I found that I like this because it really forced me to exercise a judicial temperament of being really fair, really clear, really honest, about what, and in an area that's often rather murky, do my best to ascertain, did this acupuncturist, whether I'm representing the plaintiff, the injured party, the patient typically, or representing, defending the acupuncturist, are the allegations that the acupuncturist failed to uphold their professional duties, are they fair? Are they accurate? What would a reasonable acupuncturist have done in this situation, or not done in this situation? So have continued to play that role up until this day. And I've sort of tallied about 25 cases where I've actually been retained in a formal role, but another dozen or so where I've kind of informally consulted with one party or the other. And sometimes I hear about cases and that don't actually end up going anywhere, but I'm still in discussion with the injured party or their attorneys. So that's kind of the role that I played. And the second role that I kind of concurrent with this, right around the same time, I started serving as an instructor at the master's level, first of all, and then at the doctorate level and continuing education level, regarding first day, first semester clinical orientation about safety procedures at the Five Branches University of Traditional Chinese Medicine in Santa Cruz, California, where I got my own master's degree and where I was practicing. And also teaching academic, didactic classes that are typically just a 8-hour class or a 16-hour class, 1 or 2 days on ethics and risk management. And from that, I learned, I've discovered that, or I should say, some of my qualms about how we've been trained at the master's level were confirmed by some myths and misconceptions and sort of states of denial or confusion in the education of our profession at large, that I realized, kind of putting these two pieces together, it's like, wow, this is why people are winding up in trouble, getting sued, getting complaints filed against them. And so that's something that I'd like to speak to a little bit about, sort of what are some of the common myths and misconceptions in our profession that lead us astray and get us into trouble. Now, in terms of those complaints, I'm going to kind of break it into 3 parts. There's the malicious patients. Unfortunately, there are a few of them out there that are truly, I've worked on a couple of these cases where it's obvious somebody actually gave themselves a 3rd-degree burn with a heat lamp, went home and burned themselves. Apparently, from all the documentation, it's pretty clear that this did not happen in the clinic, but blamed it on the acupuncturist. Those are really rare. I've only served on a couple of those where there was some kind of vengeful or financial gain or racial hostility or something like that. There's also been a couple with obviously malicious acupuncturists who were, in addition to an injury that they that occurred as a result of their care, they had, sexual impropriety, fraudulent billing practices, et cetera. And the vast majority have been, neither of those, have been essentially well-intentioned acupuncturists who made some mistakes, or didn't handle scenarios well, And because of essentially, I would say, a lack of training and a lack of attention, or, confusing agendas, trying to make too much money in too little time is probably one of the big ones, rushing through patient interactions too quickly. Um, so, out of that, I started really, focusing more on turning around and sort of, talking back to our profession, saying, hey, we do have some problems here that we need to address, particularly because, we hold ourselves high and mighty as the safe medicine, and, it's only the physical therapists who cause pneumothoraxes, and the MDs who are killing people with drugs and surgery and stuff. I'm like, no, I've served on 2 death cases. One, a pneumothorax death, one, an acupuncturist who told their patient that all the Western drugs they were taking for their medical condition were toxic and had all kinds of terrible side effects, even though they didn't explicitly say you should stop taking the medications, which would have been an obvious scope of practice violation. The patient took it that way. When you're wearing a white lab coat in your clinic, and somebody's paying you to render care, and you offer very strong opinions, even if it isn't specific advice, it can be, correctly or not, taken by the patient, maybe misconstrued by the patient. But if it winds up in a death, family's going to come after you. So these are some of the things I've learned, and that I want to share more with the profession. I'm really grateful to every panelist here, Lisa Rolleder, who I made contact with about a year ago, with, sort of like, wow, we're kind of seeing things, and there's a lot of convergence here, even though I practice a very different style of kind of one-on-one orthopedic practice, and Lisa practices and teaches in a community clinic. And with, grateful to Ben and Anne Marie for pulling this together, because I see it as a real necessity of our profession to, as we feel under threat and under encroachment from physical therapists and chiropractors doing dry needling and so on in other states, we have to up our game. We can't sit in the glass house and throw stones at other people. I hope that sort of addresses the initial questions that, Ben,
Yeah.
you're asking about sort of my role and what I've learned and what I want to bring to the table here.
Thank you. I'm going to sail a couple more quick questions by you. What ought practitioners do if there's an incident? What to do, what not to do? And I know that's its own 6-hour course, but
Excuse me.
Everybody.
Yeah, it is a 6-hour course. I think what I can drop now is just some very succinct, here's how I would answer that question, Ben, is that usually by the time that a patient has filed some kind of a complaint, either a legal suit or a complaint to a regulatory board, or both, as often happens, then it's I don't want to say it's too late, because there's still some ways that you can make the situation worse or make the situation better. But really the question begins with how your fundamental training and how you set up your intentions and your practice in the first place. But I'll stick to your question here, and I would say that a couple of things that I think I'm just going to echo what Ashley said, that documentation is absolutely critical. And I have helped acupuncturists get off the hook and not have their license suspended or revoked because their documentation was meticulous. And conversely, a common feature in a lot of the cases where I've served representing the plaintiff is the documentation was shoddy, terrible, sometimes completely absent, or so cursory or rote as to appear just like copy and paste without any attention to what was actually going on, or fraudulently altered and tampered with after the event, or only documented after the suit or the complaint was filed rather than at the time of service. So documentation is a big one, including, I'll just throw out one little piece that I've learned is absolutely crucial, which very few people do, which is when you're needling over a critical structure, you need to document the angle and the depth of your insertion or the length of your needle, because multiple cases, particularly pneumothoraxes that I've served on, have hinged on this very question of how deep did you insert and what angle that either did or didn't cause a pneumothorax injury. So, and I know that might be an alarming proposition, and that many of you are thinking, oh my God, I'm going to be up till midnight every night if I have to document. Not every needle, you don't have to document that with, triple warmer 5 or whatever. But over critical structures, I think that's really highly advisable. So that's just a piece, but probably one of the most critical pieces. And the other thing that if a complaint has already been filed, or you're aware that one is pending because somebody has written you a very angry letter demanding some restitution, or left a voicemail or a text or whatever to that effect, is to take responsibility for the situation and act in the patient's best interest, in coordination with the advice that your malpractice insurance company gives you. Your very first call should be not back to the patient, but should be to your malpractice insurance company. I've just received, I had to do this once with a patient who was very angry and demanded a refund of their payment for 3 treatments because she had some ongoing pain in her hand after needling small intestine 3, and apparently it was just a nerve trauma, which will typically die down on its own, within a matter of a few weeks or so. But she was upset, hurt, and angry enough that she, left an angry voicemail demanding restitution. And had I called her back right away without, in a state of, upset, worry, concern, defensiveness, denial, etc., I could have made the situation much worse. But I chose to call my malpractice insurance company, and they said right away, you did the right thing. We're not going to raise your premiums, but here's what you ought to do: refund her entire amount right away, no questions asked, no contest, and do what you can to express your concern and take responsibility, and act as if, essentially keep acting as if she were your patient coming to you with a new injury. A patient comes in and says, I have a nerve injury. And how would you respond to that? You would, you'd want to get full information, do your physical exam, render appropriate care. I'm not saying that, I treated her again, but that's the mindset. Treat them as if maybe it was, your best friend or your family that you hurt, rather than somebody that you want to shy away from and get defensive about and withdraw from. So those are a couple of the after the injuries occurred, that's kind of what I would suggest. But really, I would defer to Ashley on this, because she's in the position to know exactly how does a malpractice insurance company advise their clients when there's an allegation of an injury.
Well, in Q&A, let's make some more time for that. And we're going to move on to Lisa, Anthony. And one thing I want you to be thinking about in your free time is you shared a handout on attorney and expert witness interview of an injured patient. And when we circle back to the moderator questions, I want you to share a little bit about, share some pearls about how to take that document that you generously shared and use it as a frame of reference for patient care.
Sure.
So yeah, thank you, Anthony.
Thank you.
And let's move on to Lisa. Lisa's going to share a bit about big picture as a large clinic owner. I notice in a lot of your material, Lisa, you don't refer to community acupuncture. So I'm interested in how you relate to that terminology now, or maybe you still do identify with it. And I'm really looking forward to hearing you share about trauma-informed care. So thank you.
Hey, thank you. So I've been an acupuncturist since 1994, and I'm a community acupuncturist, and I work in a school that trains community acupuncturists. And so it's a very different kind of milieu than a lot of people, but I really want to echo pretty much everything Ashley and Anthony said. And I'm just going to fly through a little presentation we do for our students about safety, because definitely echoing, I mean, I think a lot of practitioners feel like they didn't get enough safety training in a certain way in school. So I'm just going to fly through how we introduce our students to the topic. So we focus a lot on culture, on creating a positive safety culture. And if you think risk management or having a practice is like gardening, a positive safety culture is like the soil. So really interested in the composition of the soil. And a good thing about safety culture is it's a very wide angle lens, and it's looking at doing things for positive reasons, as opposed to just necessarily the fear of being sued or the fear of something bad happening. So I find it's more empowering to focus on what are things we want to do to create safety, both for patients and for ourselves. And yeah, risk management is partly about math. So a positive safety culture is super important in a high volume setting, which is what community acupuncture is. So if you're going to treat a lot of patients, it's really important that to think about, well, what can I do to create an environment of safety? And so we have an expansive definition of safety, and it includes basic physical safety, do no harm. We also include the idea of social safety or feeling safe with other people. And that can really affect, when patients are upset or have an adverse outcome, the more social safety, the better. And then trauma-informed care, which I'm going to talk about a bunch. And we think about things in terms of harm reduction and, of course, risk management. So trauma-informed care is a really big concept in public health these days. It's been gaining steam for a couple of decades. And it's about recognizing the prevalence of trauma, meaning that there's way more trauma than most people think there is. And I know sometimes now people are like, oh, this is a buzzword and it's overblown. It's not. It's very, very common, and it's really useful for practitioners to expect it. Trauma-informed care is really about cultivating transparency and collaboration to promote trust, and really working to avoid creating adversarial relationships, which is super important when you're navigating safety issues or adverse events. The quote, there's a website, a great website called Trauma Informed Oregon, and the link is in the materials. And it says to be trauma informed is to provide predictability, safety, trustworthiness, and neutrality as ways of valuing the individual. So I'm going to probably circle back to some of those themes. So a big idea about trauma-informed care is that the goal is to avoid re-traumatizing people, which is very easy to do in healthcare settings. And it happens all the time. And especially a lot of patients who have chronic pain or who have had complex cases and have been through the healthcare system in various forms, they have probably had traumatizing experiences. We think about it in terms of it's like universal precautions for trauma. It's kind of exactly the same way you think about universal precautions for bloodborne pathogens. You assume that everybody has a trauma history and you proceed accordingly. And we find that helps a lot with risk management. So trauma-informed care in community acupuncture or anywhere else, it doesn't mean attempting to treat people's trauma with acupuncture. It means recognizing and mitigating the ways trauma can show up in the clinic and or get in the way of people's access to acupuncture. So when you're talking about people being upset, feeling worse after treatment, having mysterious reactions, sometimes that's about a trauma history. So from our point of view, practicing trauma-informed care reduces your risk of claims because you're focusing on the idea that safety is something that everybody wants and needs. And it's something we can always work on and feel good about. As Anthony said, that's a way of raising our game. I hear a lot of negativity about safety when you talk about it, like, oh God, that topic. But we try and go at it towards this is really important and really valuable, and we all share this need for safety. The idea is adversarial relationships can be created not just by like human interactions, but by systems. Like, are there things in your practice that are consistently making patients frustrated? If so, it's really important to deal with those. Trauma-informed care focuses a lot on good boundaries. No pressure, no surprises, cultivating transparency for people. So as Ashley mentioned, just being really clear about policies, really clear and really consistent. Basically, if you're working on not re-traumatizing people, you're also working on mitigating risk factors that can lead to claims. I'm going to share a recommended book if you're interested in the topic. There's a great book called Trauma Stewardship by Laura Lipsky and Connie Burke that gives an overview of the whole topic. But okay, common trauma triggers in healthcare settings. I learned about this from working with patients and providers in safety net clinics like Medicaid. And again, this is something that safety net clinics put a lot of attention on. And so according to the psychologist, social worker who I learned about, who I trained with in these settings, her name's Laurie Lockhart. Here's a list of common triggers. And if you think about how they show up in your practice, sometimes you can identify ways of like, this is how people can get very upset very quickly. So one is authority figures. As Anthony said, when you're wearing a white coat, there's this extra dimension. Another issue is sensory cues of past events, which you may not be able to control at all because they come from the environment, but it can happen. Feeling a lack of power and control, that can really trigger people's trauma. Feeling threatened or attacked, caught by surprise, feelings of vulnerability and rejection, sensory overload, so too much, too fast, and shaming. So these are all things that we look out for, and we're like, we want to avoid those if we possibly can. So I think it's important to understand that when trauma shows up in the clinic, it often does not look like sadness. It doesn't look like somebody coming in and crying. It might, but very often it looks like something else. And so the list, that we teach our students to watch out for, if you have somebody who, it's like, we call it like a 0 to 60 type reaction, like you're having a conversation with a patient, you're putting in needles, everything's is going fine, and suddenly things are completely off the rails. They're upset out of the blue, or they come in late for an appointment and they're checking in and everything seems fine, and suddenly they're yelling at the receptionist. So these kinds of nothing to over the top, that's an indicator for trauma. Trauma sometimes looks like anger in all its forms, from on the spectrum from scary, explosive to low-key irritable. Panic attacks. Worst case scenario is someone running out of the room with their needles still in. Anxiety about everything related to the treatment process. So people asking tons and tons of questions and making it actually hard for you to treat them because they want to know everything about everything. Sometimes that's a sign of a trauma history. Especially though, I want to highlight the last two because they really can show up, I think, in situations where claims happen. When people are triggered, sometimes they react to you as if you are trying to hurt them. And it's very easy for a practitioner to become defensive in that situation. And it's helpful to understand that possibly what's happening is you're seeing a trigger. And the topic of what happens in somebody's brain when they're triggered is too big to get into here. But for these purposes, just to know that sometimes patients will react to you as if you're trying to hurt them. You didn't do anything wrong. They didn't do anything wrong. This is just what's happening. And finally, unexpected physical sensations. So you're needling someone and suddenly they're like, I can't breathe. And you're not needling their lungs. You're not needling, you just maybe put in stomach 36. They can't breathe. Or they suddenly feel really angry or really scared, or everything hurts. And they're like, why does everything hurt? All of this can indicate a trauma trigger. So to minimize potential triggers, you basically want to think about creating a container that's characterized by being really consistent, being really neutral, like lowering the emotional temperature for everybody, minimizing defensiveness, having transparency, and just feeling like we're all on the same side. What you don't want is for risk management to feel like an us versus them. You can approach it like a cooperative project with the patient. So in our experience, everything starts with the intake. Like that is the place where you set the tone for a positive, cooperative, non-adversarial relationship. And so again, just stressing consent, 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 written consent, but also verbal and also nonverbal. We teach students to really watch people's nonverbal reaction and read their body language. Because that can be really important, where someone is verbal with their mouth is saying, yes, it's fine if you needle a point on my stomach, but their physical reaction is they're pulling away from you and they're getting stiffer. And then you're like, wow, I don't think this person really wants to do this. So again, no pressure, no surprises, make it easy to stop the treatment at any time. Make it clear that patients can be like, if they want to be like, no, I don't want you to needle that, your response will be, okay, sure, no problem. And in the intake, we end with our statement to everybody is, let's see if you like this. Not you have to do this, but let's see if you like this. Like focus on them feeling empowered in relationship to getting treated. And I think that is all I want to say about that, except that we have this thing, speaking of being obsessed with safety, our school has something called an adverse events reporting database, which anybody can report to, a patient, practitioner, anybody not associated with our school. And we periodically go through and mine reports. And as far as we know, this is the only AERD that the acupuncture profession has. I don't think, I think it would be great if more people were into adverse events reporting, but it's great for our school. And just to give you an example of something that came up pretty recently that someone reported, they needled a patient who was wearing an Apple Watch. And I think they had PC6 in. And not long after they needled put in the needle, I mean, everything was fine when they did it. The Apple Watch sent out a notification and the patient got a horrifying shock down their arm. So one of the things we did is to let everybody know, kind of watch out for smartwatches. Because again, this isn't something where the patient needed follow-up care. It was just a painful surprise, and we don't want those to happen. And we're trying all the time to avoid unpleasant surprises. Okay, I hope that wasn't too fast. Was that okay?
No,
That's what
we
I've
really
got.
appreciate your perspective. Anne Marie has a question about informed consent practice.
Yes.
Hi, Lisa.
Hi.
Could you speak a little bit more about your recommendations for that initial intake and setting that tone? Because some practitioners maybe don't allow a longer first appointment, to do the intake, or they just have 45 minutes or 60 minutes, and you have to do the informed consent, take the medical history, right, and take their pulses, do the treatment, and then get them, close that out, get them to change clothes, whatever, and be on their way. That's a lot in 60 minutes. So I know that you're in a community acupuncture setting, but can you give us an idea of how you do that? And, Anthony, this is a question for you too. What do you do? And then what are your recommendations for best practices so practitioners can evaluate how they're doing it? Because that verbal discussion is really important, and I don't think that it happens very often.
I should say, I mean, it's going to be interesting in some ways, like we're doing something really different. Like our appointments are quite short. When I say we're not necessarily talking to people in tons of detail about, well, you realize that you could have nerve damage or something like that. It's not so much that. It's focusing. I think it's a matter of intention, of like focusing on whatever you're doing, you're watching for consent. You're not focused entirely on how can I mean, for us, it's all about, does this person actually want to get acupuncture? Do they feel safe? I mean, and one of the advantages for us, which is different in an open treatment setting, people look around and they can see other people being treated. So they can basically, once they walk in the room and look around, they have an idea of what's going to happen. So if someone walks in the room and they look and they recoil, the acupuncturist's goal is not to get them to sit down. It's to ask them, are you sure you want to do this? Like to just make it really easy for people to say, I've changed my mind, or I have concerns, or something. You're just basically we're looking for enthusiastic consent. And if we don't see that, we keep working on it until it's there. And if it's not there, you can always say, hey, do you want to try this another day? And again, without being shaming or like you failed somehow, like we're very much like, this isn't necessarily everybody's cup of tea, but we hope it's yours.
And do you chart that, like for those who say, no, I think I want to wait,
What
put
would go in their
something
chart is
yes.
patient decided not to do it. Yeah.
Can I just add one thing to that? In my world, we call that informed refusal. You don't necessarily have to write that, but that's like the term of art. But it's a very good point. If the patient says,
Anthony, do you have anything to add?
Sure, yeah. First of all, I want to basically echo everything that Lisa said. And she said she's laid out extremely well. I think the kind of relational aspect of I think one of the myths and misconceptions that I want to puncture, if you'll pardon the pun, is that there's a direct relationship, kind of one-to-one correspondence between the seriousness of an adverse event and the likelihood of a malpractice suit or a complaint to regulatory board being filed. And I have consulted with patients who've had life-threatening pneumothorax injuries, lung got infected, part of their lung removed, permanent, damage to their respiratory capacity, and not sued. And conversely, patients who had like the tiniest little moxa burn that only an intimate partner would ever see in a part of the body where the sun doesn't normally shine, and they're filing a suit. So it's the relationship is so critical, and informed consent is I would say the number one, the most critical piece of the relationship, because if you do your informed consent well, that basically addresses, I think, all of what Lisa's saying. There's no surprises. There's a sense of total control on the patient's part, that they can, decline or refuse any part of the treatment plan or the entire experience if they so want. You're taking yourself out of an authority pedestal role and putting yourself, side by side with the patient. And you're giving them a invitation to express every step of the way what their sensory cues are, if they're feeling overloaded, et cetera. And it is a uniform feature. Every single case that I've served on where there's been a failure to provide adequate informed consent or informed consent at all, or hiding behind a piece of paper in 8-point type that's 2 pages long that the patient just signs. I mean, how many of us, when I go to a doctor's or a dentist's office or whatever, do I sit there and read line by line and understand everything that's being said? No, I just sign it because I'm in pain, I'm feeling sick or in a hurry or whatever, and just like, oh, whatever, I'm just going to sign it. That's not informed consent. That's self-protection. And there's a big difference there. And so this is a routine question that when I teach these classes, acupuncturists often ask, well, but I have this piece of paper that was provided by my malpractice insurance company. Isn't that enough? And I say, no, it's not. It's absolutely not enough. It's the relational aspect. So here's what I do, which is, might be surprising to you, but I look the patient straight in the eye on the very first visit, and I do talk about the risks and the potential adverse effects for 2 reasons. First of all, that's part of informed consent. But second, I want them to know and understand how to manage an adverse event should it occur. Should they start developing, adverse reaction to care, not while they're in the clinic, but after they leave. I want to understand if they're having chest pain, difficulty breathing, shortness of breath. No, it's not asthma, it's not COVID. If it's within a day or 2 after an acupuncture treatment where their needles were placed over their thorax, they need to seek emergency help right away. And sure, call me when your situation is safe and stabilized, but you really need to go to the emergency room. And in 15 years of doing this routinely on every single initial encounter, I have never once had a patient decline to proceed with treatment. I sometimes had a little bit of anxiety and a few questions, but actually what I've had most commonly is patients saying, oh my God, I've seen a dozen acupuncturists and you're the first one who ever said this to me. I had no idea that acupuncture could cause this. Thank you. And why didn't those other acupuncturists say that? I don't know. I'm sorry. It's a failure of our profession and training, because it should be routine and built into every single initial consult. It's just, and not a big deal. And so what I suggest in the classes that I teach is write out a script for yourself about how you're going to do this. Find another colleague of yours and they write their script, and you guys just deliver it back and forth until it becomes boring to you. And it's boring to me when I say it. It's just like, I don't mean boring in a disaffected, alienated, disconnected way, but I mean a low-key, calm way where it's not a big deal and not trembling and shaking and feeling guilty or anxious as I'm saying. I'm just like, I just want you to understand these are very rare, but potentially quite serious adverse events that can result from acupuncture and other procedures that, talk about, have my list, and it's, heat lamp burns, et cetera. And then the conversation gets documented in my chart. And that's one of the great virtues of electronic health records, is that part can be boilerplate. You just have your informed consent conversation, you document it, you edit it slightly if the patient asks any additional questions or declines any part of the treatment, whatever. But it's not a big deal. It should be routine, should be low key, should be ordinary, and it's a huge trust builder and relationship builder.
You bring up a good point, but I also want to add that I think it would be important, treatment 5, treatment 10, if you're introducing a new modality, right? Let's say all of a sudden something happens, you're normally not using cupping. Now you want to introduce cupping, right? Have that conversation again, give them a handout, right? Make sure that, because they're not going to remember, especially if it's like 2 months later. So do you have any comments about that? But that's what I found to be really important in my practice.
Yes, that's a good point, Anne Marie. It's informed consent is procedure specific. So anytime you're introducing a new procedure, even if you've seen this patient for years, but now suddenly you're going to, do 7-star needling and cupping, just talk about whatever risks and side effects are specific to that procedure. And it doesn't need to be repeated. Basically, once consent is the relationship needs to be, maintained in a positive, beneficial, therapeutic way. But the conversation, you don't have to do that at every single visit, but you do need to do it the first time you introduce any procedure. And if a patient, after having, tried it, declines, then that's definitive. You don't administer anything that anyone has, refused or declined to accept as a treatment.
Right.
I have some questions about adverse event reporting. I'm thrilled, Lisa, that you keep a database about that. As a FDA registered dietary supplement manufacturing company, we're legally obliged to do this. And we're legally obliged to report to the FDA if there's a serious adverse event. I don't think that's been delineated as a legal definition today. And that Ashley alluded to this, that serious adverse events, legal definition is the things that require hospitalization. Not just follow-up care, but actually require medical intervention to sustain life or prevent more serious harm. And adverse events are things that happen all the time. And if the FDA comes and visits for an audit, they'll be concerned if you don't have documented adverse events. And so I think that practitioners are in fear of documentation because there might be fear of repercussions if those are ever subpoenaed, or they might lose their insurance policy. And so I'd like to hear your perspectives on where you think, this is from everybody. We're deviating a little bit from our form because we're fielding some of our questions from different panelists, but I think it's fine. Where you think there may be risk in reporting, to which bodies, not just your insurance company, might you want to report serious adverse events?
If I could speak to that.
Yeah,
So for our little adverse events database, we're not differentiating seriousness. And in the research we did, when we put it together, all the safety data says the same thing, that people, this is separate from herbs, because the acupuncture profession doesn't have anything formal like that with the FDA. So, but outside of situations like that, all the data says the same, that for it to work, it has to be voluntary. People only report if there's no fear of punishment. If there's fear of punishment, they won't do it. So our database is anonymous. And some people identify themselves, but we're very clear that the goal of it is just better communication about what can happen. And I want to echo what Anthony said, and people who don't like our database protest the existence of it because they're like, well, it's making us look bad or it's trivial. But we file a report anytime a patient is upset. And that can be the tiniest bruise versus one of the reports I got at one point was from an acupuncturist who was reporting a patient, because we treat in recliners, the person, again, PC6, fell asleep, rolled their arm over and skewered their tendon. They had to go to urgent care to get it removed. The person was back for treatment the next day, not at all upset, took it in stride. And so what we're trying to do two things is just establish a feedback loop when patients are upset, because there isn't any other way to get that information other than, if they call or something. But I mean, in terms of your state body, if you're if you are dealing with a malpractice claim, at least in Oregon, you're required to report that to your licensing body. I imagine other states might be similar, but that's something you should find out, like what is the rule in your state. But other than that, from my perspective, it's important that there be no negative consequences whatsoever, and that the possibility of anonymous reporting is there so that people will share stuff. Because I mean, just again, Anthony and I are really on the same page about this, so frustrated about the quality of discussion in the acupuncture profession about safety. Like, you have people being like, we don't have anything, nothing ever happens. And that's not true. Like, we need to be able to talk about the things that do happen. Okay, I'm getting off my soapbox. Sorry about that.
Thank you for getting on it, Lisa, because I was so thrilled to find that you had this had created this fantastic resource for the profession. So how are we supposed to learn if we don't learn from the mistakes of others and our own mistakes? I mean, it's a fantastic teaching resource for us, as well as as a kind of fulfilling an important role in terms of data accumulation and a place to report events. So I so appreciate that you're doing this, and I think that this is exactly what the profession needs, is a way to learn from the injuries and adverse events that do occur, or the perceived ones too, because those are equally important. Those can land a practitioner in every bit as much trouble as a real injury. Is the patient thinks that something bad has happened to them because of the acupuncture or the herbs or whatever, even though there's no credible, plausible, possible relationship between the two. But because it happened after, it happened because of, it's a common logical fallacy in human existence, right? And so it's a great resource for all those reasons.
And just getting back to the discussion about how to handle when patients are upset or telling you something that you're very surprised at. For us, we teach students to say the first thing out of your mouth should be, please tell me more. And the second is that you're taking notes. And finally, in our world, we tell people to say, we're going to report this to our little database so that we can figure out what led to this and make sure it doesn't happen again. And that strategy works just as well with perceived adverse events. That could be a whole topic of discussion, perceived adverse events. And again, when you're treating people with chronic pain, they are used to not being believed. And I can't overstate the relational importance of just listening to people and not arguing with them. Okay, sorry. Yeah, soapbox.
Just so everyone knows, I added the link to the database in the chat, and we're also adding that to the webpage where you can download handouts and documents.
We're just gonna, with mindfulness of time, cycle through some of the moderator questions that we've queued up. And I want to ask Ashley, what are some of the common denominators in acuclaims and litigation?
Acupuncture claims, in every case I've handled, I've seen poor documentation is a common denominator. And it some of the things Anthony talked about, sometimes it's I've seen records that are and I've seen this in all specialties prior to EMR. I've seen, I wrote everything down. Well, if it can't be read, make sure that the documentation is clear and legible. I would say that's one thing. I think poor documentation is a common denominator. I will say one thing. If you have a claim, or if there's litigation, if you make a note after the fact and that's found out, it is a de facto finding for the plaintiff. I mean, I've seen cases settle like that if there's fraudulent record keeping, or someone changes the record. So I would say never, ever, ever go back after the fact. Just sort of cautionary tale there. So with regard to informed consent, I would say lack of informed consent is a common denominator, but I think there's some nuance to informed consent, and the discussion so far, I think has covered a lot that's important. Yes, it's important that there's a form that outlines these are the treatments, these are the risks, benefits, and alternatives. It is equally as important, as was denoted, to have the conversation. I believe, as was denoted, it's important to have the form and then in your chart indicate, I've discussed the risks and benefits, patient has elected to proceed, patient's questions were asked and answered, something like that. It's not a get out of jail free card, though. I want to be careful, and I want to be thoughtful about that, because you can have the document and you can have the discussion, and the person might still have a pneumothorax. That doesn't mean, there will be no claim, there will be no, no settlement or something like that. What it means is that you took all the steps appropriate and the patient had experienced what's called a known risk. It means that a claim that follows, the value of that, or the ability to contain what has occurred, is maximized. It doesn't mean, you get off scot-free. There are risks for every treatment of every kind in every specialty. It means that you've taken steps to contain it. So I want to be careful about that. Another common denominator is just poor communication, whether it's patient, not responding in a timely manner to calls about, I'm having some reaction, or I have some questions, or just sort of poor communication between the patient and the provider. Sometimes in a robust practice, there's a person who's taking messages and communicating. And I've seen a lot of claims in which patient is attempting to communicate directly to the provider and can't get through the receptionist, or can't get through, Lisa talked about the systems, everybody's got a patient portal now. If you're not actively reviewing what's in that portal and you're not engaging with the system that you offer the patient, it's as good as not having that system. So those are probably the big ones. And also, just anytime someone has an injury that requires follow-up care of any kind, that's it's gonna result in a claim. And I've seen people say, I love my physician, or I love my acupuncturist, great person, but I did not count on having to have this treatment again, or I did not count on, missing a vacation I planned. And I will say, I have heard people say, I have made big mistakes and not been sued, and I have done everything right and still been sued. It's just that there's no silver bullet.
Okay. You had mentioned being cautious of communication by texting. Will you say a little bit more about that?
Yeah, so I think texting can be really valuable because it's a quick communication. And if I had a case where there was texting communication, and it was a situation in which the patient was reporting very significant side effects, or symptoms, shortness of breath, go to the ER. So the text communication should be contained. It should be limited. I do not recommend a situation in which a patient provider, it's carrying on and carrying on and carrying on. If a patient is upset about treatment or has questions, why don't you come in for an appointment? Let's talk face to face. I do not recommend engaging significantly via text. It should be brief. And the reason is that so much is lost in translation in text. I think text is defined by abbreviations. It is defined by sentences that are truncated. It is the ability to misinterpret a text message is vast. And so I think text communication should be very, very limited. The truism of people in this age is that it is a preferred mode of communication because it's easy. So I think that to find a situation in which patients aren't texting will be limited, but I would be careful about that. And I don't know, Anthony, you may have seen cases in which it's come up or it's been a factor, I'm not sure, but I certainly have seen, and I will say, text messaging with good intent gone horribly wrong is it's a commonality across all healthcare.
Yeah, thank you, Ashley, for clarifying all that. And yes, a couple of the cases I've seen, absolutely, the text exchange show up in the documents in court, the stuff that I'm asked to review as an expert witness, and I absolutely agree that text is a very poor medium for any kind of sensitive or complex communication, because even with the best of intentions, the medium itself encourages us to be. It's built on being brief, being cursory, being fired off rapidly, and that's exactly the opposite of what's needed in any kind of situation where somebody's feeling injured, hurt, needs advice, needs care, etc. And actually, I do not. My patients do not have a number that they can text me on. I do not use text at all, zero, to communicate with patients, and it does not adversely affect my practice in any way that I can see. So I keep it to email, which is not ideal, but a lot better than text for going into some depth, phone calls, and best of all is in person. However, I also want to caution about something that I've seen in a few cases where the patient is reporting a quite serious adverse event, and the acupuncturist response is, well, why don't you come in for a free treatment? Well, that's a nice thing to offer, but if it's a serious adverse event that, most state, know your state licensing laws and regulations, know the standard of care as it's defined in the clean needle technique manual for second degree or greater burns, for anything that might possibly be. So the threshold is not that that they had a pneumothorax, it's that they have signs and symptoms that possibly could be whatever it is, pneumothorax, cardiac injury, something, nerve trauma, whatever, that needs advanced immediate medical care. The standard of care is send them to the ER. And then once the situation is stabilized, hopefully it's stabilized in a way that, and if you've given them sound medical advice as to what they need to do to handle the situation, they may come back to you and they may be grateful for a free consultation or treatment or whatever. But your first response should not be, come into my office to see if in fact you have a pneumothorax or not. It should be, that's the evaluation that needs to be done in an emergency room, where if in fact you do have a pneumothorax, because delays of care can dramatically worsen the situation or lead to, permanent disability or death. So it's not the time to say, oh, well, I've got an opening next Thursday on, would you like a free treatment then? So.
Just in the name of time, maybe we want to get to some Q&A from our audience. I do want a 1-minute synopsis from you, Anthony, how participants can get value from your interview of a patient alleging injury from acupuncture care.
Yes. So that was a document that I provided with a little bit hesitation because it's probably a fairly scary one for most people to read, because this is just a whole lot of stuff that just, I've accumulated through experience, not because I was trained in this at the master's level. But what this is something that I realized I needed for myself when interviewing a patient, whether I'm serving as on the, doesn't matter, plaintiff side or the defendant side, interviewing a patient to try to determine whether the standard of care was followed. And these are all the questions that I would ask the patient, or sometimes I provide this to the attorney and they do the interview to ask the questions. And so what I would suggest doing is take a little time to look it over and put yourself in the shoes, first of all, of a patient. Looking backwards through the lens, is this how I was treated or not treated by the acupuncturist? And then look at it through the lens of you as the acupuncturist. What changes do I need to make in terms of my office procedures and policies? What Ashley called what was the term you used? That was a really good one. Your custom
Custom practice.
custom and practice and so on. How you go about working with patients. What changes might I need to make? There's no time like the present to make them. So that's what I would do with that document is look at it from both sides and look at it as if a patient had complained and now your patient had complained and now they're being interviewed by the attorney that's representing the patient or by the expert witness in the case. So an expert witness.
Thank you very much, and thank you for sharing that. One thing I want to name, having observed your practice, Anthony, over the years, some of the culture that we're advocating for, getting to the other side of the trying to make too much money in too little time. I've observed that, you're one of many practitioners who has earned the trust of medical practitioners, and careful documentation has filled your practice with referrals. And you made some effort in that direction, but it really does work. And so I think that's another beneficial side effect of this level of care and caution, is earning trust and creating a room for a different quality of collaborative environment. So keep that in mind, everybody, when you're feeling nervous about the advanced amount of documentation you might be considering. Lisa, I want to hear your take on sticky patients and, patients that test your boundaries.
Can you say more what you mean by sticky?
Well, that was actually your
Right.
language.
No, it was someone else's.
Oh, it is?
Yeah, and I thought it was just really an interesting question.
Okay. Interesting. Okay. And maybe I use that language. People who might exhibit qualities of informed victimhood, people who might reference other lawsuits they've been in, people who, I'm in situations, or I've been working in situations where, people really reveal significant elements of their trauma, and maybe exhibit poor boundaries. Patients who might be flirtatious. That might be a quality of stickiness. And where and how what do we document? Where and how can we provide qualities of boundaries to avoid different kinds of situations that create risk for everybody, and maybe recapitulate trauma.
Thank you. That was, I think it's a really interesting, I think sometimes what comes up with issues about claims is like, people sometimes will say, practitioners will say like, oh, I had a bad feeling about treating this person. Like I knew something was off, or this person is, it seems like something is weird with their boundaries. So in my world, one of our goals is to include as many people as possible. So, and I think for most acupuncturists, and I appreciate what you referenced about Anthony's documentation, like what you don't want is for people to get in the mindset of being afraid to treat people, because then you don't have a practice. You want to feel like you can treat people and you can do a good job doing what you need to do. So for us, this is where the idea of neutrality is super important, that you're coming from a place where you're as neutral as possible. And if you get the feeling that someone's boundaries are poor, you can kind of deal with it neutrally, just like noticing it, as opposed to kind of having an emotional reaction yourself. And to me, this is where systems are so important. And your concept of custom and practice, of like, what that you essentially strive, although you tailor treatments to what individuals need, on a certain level, you treat everybody exactly the same. You treat everybody you like in the exact same way that you treat people you don't like. And one of the values of our open setting is that patients can see practitioners interacting with other patients. And so that helps keep us in a certain stance, which is, I've heard people call it unconditional positive regard. It's a variety of like very impersonal love. And I think what trauma-informed care adds to someone who's like, might be identified as like sticky or poor boundaries or flirtatious, you can come with compassion from that. Or someone who sees themselves as a victim, odds are they probably have been a victim. Like, nobody chooses their coping mechanisms. And so if you go in with this attitude of like, there's probably way more trauma in my patient population than I'll ever know, this person has probably been through something terrible. My goal is to make sure they have a good experience with acupuncture in my clinic, and to be not take it personally if it's something they don't want to do. So to essentially hold the container so that everyone is having a very similar experience. And my experience with that is that if people are, we've been very lucky to not have experience with malicious patients. And I think there's something, though, you can set things up so that people who are looking for a fight around boundaries will maybe self-select out. If you're leading with very strong, very clear, very kind boundaries, you basically have nothing to offer except good acupuncture. You don't have any drama to offer. So for us, it's about, I believe Anthony said, like, taking responsibility for the tone you set. And sometimes people will, we have some people in the student clinic where I'm like, this is great. Students are getting a workout on their boundaries because they have this person who's going to like push everyone. Like, we're super appreciative of those patients. And it can be a little more challenging as a practitioner to go in and be like, I am so appreciative of the person who really tested my boundaries, because now my boundaries are better. But that's the attitude we're trying to inculcate, as opposed to being like, that's a bad patient. Like, if you ever find yourself thinking that's a bad patient, you probably need to look at your own boundaries and be like, what do I need so that I could treat them as kindly as possible? I hope that was clear.
That's fantastic. Yeah, thank you. Anne-Marie, would you like to field some questions from
Sure, there was a couple in there.
our colleagues?
Yes, there was a couple in there that were pretty straightforward that we can answer. Please share your thoughts on the acupuncturist using the phrase "I'm sorry" from the perspective of malpractice company or a legal witness.
Well, obviously I can speak as practice company. In our world, it's okay to say you're sorry. It's an expression of, it's acknowledging something's happened. It is not considered legally, I did something wrong. I'm wrong. So they are, it is not an admission of liability. I think the thing that is important to consider, though, is, and I've encountered this a lot in all claims, acupuncture and otherwise, is the perception. And it can be a patient's perception. Well, he or she said they were sorry, and they wouldn't say they were sorry unless they knew they did something wrong. And we always have to counter that with, this is a practitioner expressing, you know, empathy for what you've gone through. So I think I personally think it's okay to say, and it's not something that MIC as a liability carrier has the position, you should never say it. But there may be carriers in places that have a different take on that. I do think that each situation is unique, and I think it's important to consider that. And so you know, having an apology can be a really powerful relationship builder. And I know that that's something that, you know, we feel very strongly about, the ability to restore a relationship. And sometimes that starts with a provider saying, I'm sorry this happened to you, which is not, I'm sorry I did something wrong. I'm sorry this happened to you is exactly what that says. So that would be my perspective on that.
Anthony, do you have anything to add, or I can move on to another question?
No, not really. I think Ashley's summarized it very well. I think what I would say is it's hard in the moment to remember the wording that you've been advised to use, though, and there's sort of a second level to this. And there's a couple things I can recommend, and one is, again, you know, writing out scripts in advance. You know, prepare now. Assume that at some point, if you stay in practice long enough, you're going to, you know, inevitably. I mean, I've had a couple of patient encounters where I'm like, oh gosh, this could go really bad. And actually, I think one of the myths is that the more experienced I am, my risks go down. I think it's actually the opposite, for a variety of reasons. But one of them is simply that you're just seeing more people, and there's a statistical inevitability at some point you're going to either cause an injury or the appearance of an injury, or encounter a malicious patient, even though those are very few in number. If you treat enough patients for long enough, they're out there. So, you know, have your scripts, prepare as if it's going to happen. The second thing is this, because kind of cycling back around to the boundary and relationship issue. Something I remember, you know, sort of a mantra that was, you know, in the practice management class that I took at the master's level, is kind of treat your patients like family. Well, if you really think about that, that gets pretty complex. I mean, I don't know about your family, but they're very diverse, and there's some family relationships that are really strong and trustworthy, and some that are like, oh my God, you know, I'm definitely, you know. So here's a suggestion. Don't treat them like your nuclear family. Treat them like a distant cousin, where, you know, yeah, they're family, or, you know, a friend of a friend, you know, somebody that you definitely would not want to offend. You'd want to deliver your best quality of care, but you don't have all the sticky emotional relationships that you have with your closest family. You have sort of a distant family, but, you know, human family. And so maintaining those clear professional boundaries, kind of like a very good mantra that, you know, I learned from parenting books, is kind, firm, and clear. Kind, firm, and clear. Kind, firm, and clear. Kind, firm, and clear. Great way to parent, great way to interact with our patients. Yeah.
Great.
And then if something goes wrong, then you treat it like I accidentally, you know, without acknowledging guilt, or, you know, which is kind of an emotional reaction, is exactly what Ashley said. It'll be much easier to find your way to that place of saying, I'm sorry that this happened, without you being emotionally entangled in, oh my God, I just hurt my mother or my child or whatever. You know?
All right, here's a clinical question. It's kind of long. Speaking of inviting patients to call you when stabilized, do they call the front desk, or do they call you directly, or do they ask for you? What guidelines would you recommend when working as a 1099 employee for someone who contracts for insurance billing of the patients you treat? Should you advise them to notify you as the person treating, or the business owner?
That's a few questions rolled into one.
Yeah.
Yes.
So
Start with the first
let's
one.
start with the first one. So if someone has complaint and they're stabilized, who should they call? Should they call the front desk? Should they call you directly? I mean, different clinics are set up in different ways, right?
I also think it's gonna, the acuity of the complaint or symptom or reaction to care is going to define that. I would say it will be very situation specific,
Mhm.
in my opinion.
And what about situations where you're an employee? Right, and so you find out about it. When do you get the owner of the clinic involved? How do you get involved? Um, what would you recommend about that, sort of procedurally taking care of that patient, responding to them? Anthony or Lisa?
I mean, I can speak to a situation where, there are multiple people involved in a clinic, and kind of another layer is once you have employees, then you have OSHA. You're responsible for OSHA, and part of OSHA is simply having safety meetings. And we have a designated safety person. So in my world, when an employee hears about something, first, I mean, the first goal is to get more information from the patient, and then we would talk to everybody kind of immediately. Like, why would you wait?
Mhm.
Communication is a huge piece about safety. Like, I can't think of a situation in which it would be inappropriate to say, I heard from a patient that they had a bad experience. Like, that should be circulating amongst everybody immediately.
Mhm. Mhm. Okay, I know we've got like 10 minutes left, so I just want to address one or two more other questions and then we can wrap it up. But one person is saying their practice management software doesn't require that they sign off on their notes. And they haven't been signing off on their notes, which is surprising to me. I didn't know that existed. How would that be viewed in the event of a lawsuit?
Poorly.
Yeah, I would say it's time to start looking for a new record keeping system.
So I thought that was a legal requirement, like
Thought
Yeah.
so
for
too.
Surprised that
the
somebody.
EHR, it's a legal requirement.
Yeah, that's what I thought too.
Yeah.
Regarding texts, what would you do despite having a written clinical policy signed by a patient stating that you do not text or respond by text? What do you do when a patient continues to disregard the policy and sends texts? How would you document repeated unsolicited text? How would you respond and how would you document it?
I guess I'll take this one. I think you restate your policies and procedures. And you state, if there's something you need to communicate to the clinic, email, call, use the patient platform. I think I would just restate the mediums of communication that you have. If the patient is communicating significant things via text, symptoms, side effects, I would, strongly reinforce the policies. You don't want to completely disregard any, clinical response. You don't want to ignore that. I think if a patient, for example, if a patient sends a text message and you do not communicate via text message, but the patient sends a message, which is, I'm having unexplained bruising that started after treatment, or something that isn't expected, or something that is frightening to them, that, I would document that in the chart if they're having a reaction of some time. So there's, again, situations are different. It's going to matter on what's the content and what's the context. But if it's not your policy, it wouldn't be good to sort of universally ignore. I think it's important to re-communicate what your policy is.
I think I could just add to that briefly that if you reply to a text by text, you're going to keep getting text. So
Exactly.
you use a different medium to reply and make it clear that that's the medium that you use for communication, not text. And there's another piece of this too that I think, some of these scenarios, this is one sign in some sense of a patient who by, is, willfully testing boundaries. And, Lisa's approach is laudable for the attempt to include everyone to make care accessible to everyone. But I have consulted with a handful of acupuncturists where they're in a very threatening situation with a patient who clearly actually is out for something, whether it's financial gain or is trying to establish a romantic relationship or something. And another, it's too big a topic to go in the time left, but it's a topic that needs to be addressed better in the profession, is how to terminate care with a patient in a professional way that does not leave you open to charges of patient abandonment, which is one of the tools that an angry patient can use to get back at you, is charge you with having abandoned their care. There are ways to wrap up and terminate a patient practitioner relationship, but has to be done with real delicacy, real care, and in coordination probably with your malpractice insurance company to do it in a way that protects you and doesn't leave you open to those charges. So.
No. So I want to be mindful of time. There are more questions, but we could go on another hour probably. And so what I would say is, for the attendees, if you find this really valuable, this topic and the panel, please let us know. You can find my contact information in the handout, and we can create more presentations and more continuing education classes and dive deeper into areas of boundary or informed consent and things like that. Ben, do you want to add anything before I wrap up?
No, I was going to really cycle through really quickly and mention the sponsors.
Yes.
And wanted to make sure that we mention what the next couple of events are as part of our wrap-up. And I really want to provide extra special acknowledgement to you, who did a lion's share of the structural organizing. So thank you, Anne Marie. Just want to really see Anne Marie's hours and hours of organizing to make this event happen, and set a foundation for what I think is going to be. It's crystal clear now. It's going to be a very successful series. So
thank you. You're welcome. My pleasure.
I want to apologize to my friends who run CSOMA for face planting on acknowledging that they're a nonprofit professional state membership-based organization, a nonprofit 501c6 that advocates for licensed acupuncturists in the state of California. Really encourage you to participate in their events and become a member. They put out really intelligent content in their journal, and it is really like herding cats to create a container to hold the attention of busy entrepreneurs. And they've really done a good job over the years and are doing a really great job now. So just want to give them an extra layer of acknowledgement. And rather than belabor all these descriptions here, we'll send out a summary. All of our sponsors: MIEC, Five Flavors Herbs, AOM Professional, Pocatech, Maury West Seminars, CSOMA, New Herbs, AACMA, and AccuCare are all offering some benefits and greater details that you'll be able to see. So please engage with these sponsors, and we really appreciate their contributions to our profession and rallying people to participate in this great series.
I want to take a moment to preview what other opportunities there are for you to continue the conversation. So in this Pointing to Safety webinar series, we're going to have another one next month, and that one is focused on patient safety and risk management, where we're going to go in more depth into what are the strategies you can take, like what are the concrete things that you can do to help protect your clinic. I also want to highlight a series that Anthony has coming up. So kind of in tandem as we've been developing this, he also has been developing his own webinar series, and there's 4 of them. And the first one, I believe, is on May 30th. And one distinction that he can certainly share in more in-depth explanation, but one thing I want to point out that he can talk about that is not covered in depth here is standard of care. So insurance companies don't set the standard of care. the profession sets the standard of care. And so a clinician is the person to speak more to that than what we can get into here, and that's really appropriate for this presentation. So Anthony, can you give us a little bit of information about it, when it is, and how people can find you?
Sure. Yeah, thank you, Anne Marie, and thank you everyone else. I've learned from this panel discussion too, and I think there's a great value to having discussions like this where you hear different points of view. My own point of view, or my own experience, I should say, and recommendations is something that I'll be sharing as Anne Marie generously mentioned through a series of 4 webinars starting on Thursday, May 30th. That where I'm going to go into a little more depth and detail about how I look at this issue as both a clinician myself and as somebody who serves as an expert witness in malpractice cases. And I've designed them to help those of you who are NCC AOM diplomats get your required, 2 safety and 2 ethics PDAs for your license renewal too. So that should help you out. I think my website where you can register for the webinars or also take them as distance learning classes, self-paced distance learning classes, is included in the material that's been part of this webinar. So do I need to add anything more to that, Anne Marie?
No. I put the link to his webpage with all the information in multiple places in the handouts. And there's also a handout that's about our sponsors and additional opportunities. So there's multiple places you can find that hyperlink.
And I would also just add that I think probably all of the panelists, everyone in this discussion, we're all educators in our own ways. And this kind of, I'll go into some details in standard of care and informed consent, but I encourage you to seek out the educational resources provided by, for example, Lisa Rolleder's fantastic acupuncture consumer safety.net, if I got it right, the database for reporting. I know that Ben Zappin and other panelists who are going to be featured here teach continuing education classes, and Ben's on herbal medicine, et cetera. So basically anyone with this mindset, you're going to pick up a lot of valuable information with this orientation towards a culture of safety, a culture of trust, a culture of caring that will serve us all well and our patients even better.
Yeah. And I want to add one more thing, that I know this topic isn't sexy, right? It may not be as fun as taking an orthopedic class or some of the other, fertility class, but it's really important. And so even if you get your 2 NCCAOM safety credits and you don't need more, I still encourage you to continue learning and taking, increasing your knowledge about this and setting up those procedures, because once you have them, you don't have to put as much time and effort into the other classes, right? So spend some time. We really encourage you to spend some time focusing on these, get those set up in your clinic, and then you can maybe not relax as far as implementing it, but then maybe you don't have to take a whole series of classes in order to, so become a safety nerd like us for at least for a little while.
I just want to share that in July, Wilson Lau from New Herbs and myself are going to do a talk on herb safety, risk management, adverse events, drug-herb interactions, etc. And we welcome, if you have questions about that in advance, to reach out to us. Because that could inform what we organize for that 2-hour course. We may also be inviting somebody else to join us on that topic. Several people are asking, is there going to be a recording of this webinar? Of course, we're going to be sending out all of the handouts and a recording of the webinar to all registrants, and to our colleague and friend Mary asked, will we be able to re-listen to this webinar? And the answer is you can listen to it over and over and over again if you really like it.
Thank you so much to all of you. I really appreciate you being here, and thank you to all of the attendees. I think we had about 198, so about half of our registrants. So it's a real delight, and we hope we'll see you at the next one.
Thanks so much.
All right.
All right. Thanks,
Thank
everybody.
you all.
Thank
Good
you.
job.
Bye.
Good night.